Good evening and welcome to AMDA Grand Rounds, Pearls from your colleagues. I'm Sabine von Price-Friedman with the State of Washington AMDA chapter. I'm your host today again. This is a part of an ongoing peer-to-peer discussion on COVID-19 in the post-acute and long-term care space. We know our patients and our care teams have some very specific needs, and we want to make sure that we learn what we can about what serves them best through data, insofar it is available, or best practices that are constantly evolving, hence our weekly COVID Grand Rounds. Today, the title of our COVID Grand Rounds is Testing Our Patients and Our Patients. So Aaron came up with that. The evolution, I hope I pronounced this correctly, the evolution of an effective and practical COVID-19 testing strategy, something that's really close to all of our hearts. Lots has changed since our first COVID outbreak in February, when you couldn't get your hands on tests to save your soul. Now we have testing available. How, and that is the question, how do we make best use of this tool to prevent and contain outbreaks? How can we use testing strategically to slow the spread of COVID? How often should we use it? Who should we be testing? What are the barriers to testing and how can we overcome them? How reliable is testing today? Lots of questions. We are grateful to have three accomplished peers to guide us through our discussion. Dr. Swati Gaur is a geriatrician, involved medical director, many endeavors in long-term care. And among all of that, she is chairing AMDA's Infection Control Advisory Committee. Dr. Gaur lives in Georgia. And I'm just saying that because it just shows you the different locations we are on, and that makes a difference. Dr. Rinva Dumyati is an infectious disease physician and professor of medicine at the University of Rochester Medical Center. Her research focuses on surveillance and prevention of infections of public health importance. She is a member of the COVID-19 Long-Term Care Collaborative Response Team in Rochester, New York, and she has assisted nursing homes in managing COVID-19 outbreak. Dr. Robin Jump is also an infectious disease physician at the VA Northeast Ohio Healthcare System, where she serves as Associate Director for Informatics and Analytics in Geriatric Research and Education, the GREC. Dr. Jump serves on committees with the Society of Hospital Epidemiology of America, SHEA, and AMDA, also at the Infection Control Committee. So thank you all for coming. We're going to start the discussion with a poll. Aaron, if you could put up the first poll. How do we make best use of SARS-CoV-2 PCR viral tests? Only for patients and staff who are symptomatic? For testing the entire facility once a case of COVID-19 is identified? Or for asymptomatic staff? Or all of the above? Go ahead and cast your vote.
It's interesting. It says that host and panelists can't vote, which I think I'm kind of grateful for.
Yeah. Yeah. Evan, I'm going to rely on you to stop the voting when we think we have covered it. Okay. This is what I kind of expected, but we have votes for everything, but most of us voted for all of the above. And I think that to me makes a lot of sense, although I would say that probably another answer could have been it depends. So Dr. Dumyati and Dr. Jump, let's start with you. Which of these options provides the biggest impact to prevent COVID in our facilities? And Rinva, why don't you start out, and then Robin, you jump in from there. Please unmute yourself.
Yeah, Robin was happy not to answer those questions.
Well, there's not necessarily a right answer.
And I wanted to start by that. There's really no right answer here, and that's what we are struggling with, because there's mandate coming from different governors mandating testing, or from CMS. And I think it is probably better to take a kind of an approach there. Why are you testing, and what are you going to do with the result?
Always a good question before you do any test.
Yeah. So from my experience, I think we are in Western New York, so we're kind of had our peak of COVID-19 in our nursing home, and during that peak of the COVID, the health department came in and did a lot of testing of the facilities. And what I have learned is there's pros and cons of facility-wide testing. In facilities that are COVID naive, I don't think it really was very helpful. It was a lot of effort to do testing of 300 sometimes resident and find non-positive. I think what was more telling is the staff that was positive, because many were asymptomatic. And I think that probably had more impact on, kind of trying to furlough them and not have any infection in the facilities. But many of the COVID naive facility had no staff and no patients. So I think I favor, and it's only my opinion, if you have a limited amount, or if you have to decide, I think staffing testing is helpful, because they're the one that bring it in, especially if you're in an area like Georgia, where there is an increase, of cases in the community. The other ways you could use it is, once you have a case of a staff that's positive or a resident that's positive, is just then really test, and maybe test, you could start by testing the whole unit or test the whole facility. I think that's more helpful. Testing the whole facility depends really on the size. Locally, when we have done entire facility during the outbreak, it was not as helpful as doing contact tracing. Where is the positive staff? Where did they work? Who they took care of? Let's test those people. And then once you test them, when was the exposure? You have to wait a few days for the resident to become, positive, and then repeat it. It takes sometimes up to 10 days. I know the incubation period is 14 days, but we have seen like testing at 3 to 5 days and then testing again at 8 days or 10 days is helpful. And maybe I should let Robin talk, because I can go on forever.
Well, yes, Robin, what do you have to add to that? What do you have to add to that? I think you made some very interesting points. And see what your perspective is. And Robin, you are, what did we say where you are? Where are you at?
I'm in Cleveland, Ohio, but I'm also at the VA. So I live even in Ohio, I live in a different world than everybody else does, because it's just a different population, and they enter the VA in a different way than we typically get in a community hospital.
Okay.
So I live in a blessedly different world. It's also, we have different and better access to a lot of things than community nursing homes. So all that being said, and you can send me the hate mail later, I agree with everything Rinva said, that testing is not a one-size-fits-all approach. It needs to be tailored to the individual facility and the circumstances of the facility at that time, as well as what's happening in the community. And it's the community prevalence that really makes a difference. So as I think Dr. Gar will tell us about, as they're seeing their community open back up and the number of cases is going up, then the number of employees who are getting infected is also going to go up, and then they're going to bring you to the nursing home. I'm sure this is happening in Texas too. So in that case, doing system or facility-wide testing may not be the best approach. It might be better to focus the resources on people that are symptomatic and try to catch them early, or try to just screen staff, as Dr. Dumyati said, to catch folks early. But it depends on the situation. And this would be so much easier to decide if it weren't so complicated, right?
You know what? A truer word was never spoken. Yes. That's why we have so much time to discuss all that. What kind of testing did you do at your VA?
So we early on, we had, we started off by not allowing anybody at all into the nursing home.
Okay, yeah.
And that's not a luxury that most places have. We also are able to really implement PPE. And because we're a one connected system, anyone that was in our nursing home that we worried about developing COVID, we could rapidly move out and get them into the COVID unit in the hospital. And that was also very helpful. Yeah, and the struggle that the rest of the country is having with N95s is one that we did not have to face very much at all, because we don't have very many N95s. We've got PAPRs. And so it's just so much easier. You can go see your patient and breathe at the same time, which is nice. So when we initially had when we had our first case in our nursing home, we kept the person in place until we knew what the test result was, and that was about 24 hours of a turnaround time, which was at that point well ahead of the curve. This is when testing was still really challenging to get. Once we knew that person was positive, we had them transferred, and then we tested everybody else in that wing and did contact tracing for the employees. Okay. We identified 2 infected employees, 2 other infected residents on that wing, of which there I think were about 11 or 12. One of whom had left the day before and gone home and actually came back to the hospital about a week later with symptoms of COVID-19.
Okay, so I hear a lot of
contact tracing,
resident contact tracing, depending on what's going on in the community. How much time does contact? I'm a little worried about the contact tracing myself. I could see that in a place where there's a lot of support. Swati, do you have any advice on contact tracing versus at this point, June 25th, 2020, versus testing maybe the entire staff? Do you have an opinion on that? I would be concerned that my infection preventionist makes a mistake and we'd be missing somebody. And frankly, that would be my concern. How would you approach testing once you have a positive resident?
So as I think Rinva and Robin have alluded to, I'm in Georgia and our cases are actually going up. So it's really dependent upon the prevalence in the community, what is going to happen to your staff, because staff lives in the community, and then at the end, your end result is what happens in your nursing home. So that prevalence in the community continues. The second thing that I would actually point to is your infection control practices. I think as a medical director, I have seen, really good infection control practices starting out. And now it's that flagging. It's just, people are getting tired.
Pandemic fatigue is what I call that.
Yes, absolutely. And unfortunately, or fortunately for our residents, but unfortunately for our infection control program, we have had, knock on wood, very good results. So, we go through these lulls of 3 weeks with no cases. And then, bam, we did facility testing and we found several cases, so there are several factors that go into how we're gonna test. We did contact tracing, and that is because end of February, we decided to keep very clear logs. Anticipating that, very clear logs of which staff worked where. We did a very significant staff cohorting, including the rehab people who came into the,
very good
building. So they were assigned per unit, and we made sure that we didn't have people jumping from one building to the other. We have 2 nursing facilities. So we were very strict about it. We are still doing good record keeping. So a few weeks back, we were at contact tracing, and we were able to trace back a good 7 to 14 days back, because we wanted to identify the staff that could have potentially given this resident COVID and their peers. So we were able to do that. However, our prevalence increased, number 1. Number 2, our infection control practices, I think, started kind of going downhill. And we found that by doing initial contact tracing, as well as testing everyone in the facility, if we had, because of our clinical surveillance, if we had one resident that was positive, we just tested the whole facility. So, but that, it doesn't end there. We have to figure out what does it mean? And when what we figured out is, number one, the number of staff that is being tested positive is high. It's going up because of the community prevalence. And number two is, before they were high, but they were not, our resident numbers were not that high. This time we did it, the resident numbers were high. So we said, well, the infection control practices are kind of not where it needs to be or where they were. So we reverted to testing staff every 2 weeks and testing residents when one resident tests positive, testing all asymptomatic residents. Sabine, you're mute.
Sorry. My computer was making noises, so I kind of shut myself up. Yeah, that's interesting that you really changed your strategy and you really were nimble according to what the prevalence in the community was and how it reflected in your nursing home community. Dr. Dumyati, how do you feel in the every 2 weeks retesting? This is sort of where there's a lot of discussion among us. Once you want to retest, how often, once you're in Swati's situation where you have high community prevalence, and maybe the infection control is a little bit sagging, how often would you recommend that we retest? And I'm not talking about symptom-based testing. I'm talking about point prevalence testing now.
You know, we are in New York, so we had to do it twice a week. Yes, and the issue with it, which we had struggled with, is because of the volume of testing that had to be done, because staff had to be tested twice a week. So a nursing home that has, 300 or 400 bed have 1,000 staff, imagine. So there was a backlog of results. So the people would be tested before the result came back. Mm-hmm. And which is sometimes the first result was positive, the second was negative, which is another issue. I don't know if we have an answer. I think in a high prevalence area, like, where there is an increased community incidence, I think it makes sense to test frequently, maybe once a week, maybe twice a week. I don't think we know. I don't know. I don't think we know the answer. And at the beginning, I was thinking it doesn't make sense to test, but as we learn that testing discovers a lot of asymptomatic staff, I think there is value. The question is, what's the balance? How much is too much and how much is enough? And I don't think we have an answer right now, and it really varies. And Robin can say what she thinks, right?
Robin, I was gonna go to you next. First of all, getting your opinion on the retesting. And then I wanted to talk about something that baffles all of us. And I just had a case where I supposedly had 14 false positives. And what about the reliability of testing? And what about the flip-flopping? And I'm positive today and negative tomorrow and vice versa, I can explain, but the rapid reversion, I cannot. So
sure.
So Sabine, can I add just one thing?
Absolutely.
So for any testing to be really useful, you need a short turnaround time. Because
yes.
If the test comes a week later for a healthcare worker that's still working and asymptomatic, what do you do 1 week later when they were positive, a week before?
Out of the barn, right?
Yeah.
What kind of turnarounds are you guys experiencing in your communities?
We are experiencing many delays. Some people with the facility-wide testing of residents, some didn't come back until 10 days and some were positive. For the staff, we're seeing a week plus. So that's, whenever you think about testing, you really have to put all these factors in place. Like you need something to use to intervene, but if it comes so late, what's the usefulness of it? And I'm going to give the microphone to Robin. Sorry, Robin, I had to say it.
No, that's totally fine. So one thing, the reason why I waggled my fingers before is that regardless of what strategy people choose to adopt that suits their nursing home, but whatever you wind up doing, make it work, but please do something. I hear about facilities that say they don't have COVID because they're not testing. And that is, frankly, at this point, malpractice as far as I'm concerned. We must be looking for this in some way, shape, or form. The symptomatic screening is upon entry of the facility is one step for for employees. And then the screening of residents is one step, and testing is one step, and they're all necessary and important. We can't just, put our hands over our eyes and pretend that nothing's happening in our buildings. Okay, so sensitivity and specificity of the different tests. I think that's what you're asking, Sabine.
I guess I'm asking that, yes, that is what I'm in fact asking, and the frustration that some of us feel when we get test results that seem to be not correlating with anything.
So on day one you're positive, on day two you're negative, and on day three you're just confused. So.
Yeah, and at day three you're positive again. I know, I've seen it all. And then I'm just confused, and then as a medical director I just throw up my hand.
Right. So let's see if we can help. And the short answer is, of course, there's better information, and the long answer is, but it still has to be clinical judgment. So what we know about testing is that there's three kinds of tests available right now. None of them are FDA approved. These are all emergency use authorization, which means that the rigorous testing that the FDA usually requires for these kinds of screening tools is not being done, not out of any badness, but just because we can't right now. It's a pandemic, and that's what it comes back to at every step. It's a pandemic. Yeah. If it were easy, we wouldn't be in a pandemic. So, so there's molecular testing, which is PCR, and there's molecular testing, which is antigen-based, and then there's antibody testing. Yeah. The PCR is the one that most of us are using. That's the nasopharyngeal swab, which I affectionately refer to as the brain biopsy, because that's the one that goes all the way back and really kind of goes to the level of about the pinna of the ear, which is pretty far back.
Yes.
Yeah, and I've had it done. I had to actually do it to myself, and it's very uncomfortable.
Very.
So,
but I thought that we don't have to do that anymore. I thought that talking to experts, I heard that PCR you can do nasal, and it's also valid. At least that's what the Gates Foundation here has figured out.
Well, so right, that's the Washington State study where they sampled 500 some odd ambulatory adults going into a clinic with respiratory symptoms. Mm-hmm. That's right. Mm-hmm. Right. So symptomatic ambulatory adults. This is not necessarily our nursing home population, who are not ambulatory in many ways, and may or may not be symptomatic. So if they're symptomatic, that raises your pretest probability. But if they're not, if their anterior nares is dry, or they can't do the test, they don't have the manual dexterity, it's not a good test. And this is the thing that we don't know of how it works in nursing home residents. It works on ordinarily healthy adults that have a cold. It doesn't maybe work as well in our nursing home residents. So we're missing, it's going to lead to a decrease in the sensitivity and specificity of the testing. And I think that's something that we ought to be cautious about. So when the National Guard comes in and wants to do screening of our nursing home residents by doing anterior nares swabs, it's easier for them, it's easier on the residents, but I wouldn't use that to make our diagnoses and make our determinations. Does that make sense?
Interesting. Maybe. I think, well, if you talk about repeat testing, I think the repeat nasopharyngeal testing is not going to be acceptable by many nursing home patients, especially not patients in memory care. So I'm worried about that. Yep. And I also am not thinking that nursing home residents do it themselves, but that test would be administered by staff. And you could also think about a deeper nasal swab then maybe as a compromise. And I think staff testing could be done by nasal because these are ambulatory adults.
Yes, for staff, I think it is reasonable to go at the end of the nose and the nares.
Yeah.
But for nursing home residents, I don't know I don't think anybody knows what the sensitivity and specificity. Is this a useful test? If they're symptomatic, maybe. If they're not symptomatic, I don't know. And if they're symptomatic,
there's no studies that you know of, right? I mean, there's no evidence. No, of course not. I'm just asking. No, no,
nothing I know of.
Yeah, so locally, I think only staff testing, we do nasal. For the resident, we still do nasopharyngeal. And then there's questions about saliva and other sources.
Yes, what do you think about that?
Robin, do you want to comment?
So I don't know about saliva and PCR. So this is what I wanted to get back to on the testing. There's so many things that we don't know, and these are all emergency use authorization. So this is all still kind of the wild, wild west. Saliva is also being used to look at antigen testing, and the advantage of the antigen testing is it's rapid. You can get that turnaround time in minutes. And if it's positive, that seems to carry more weight. But if it's negative, you still have to do a second test to make sure that it truly is negative. And remember, the whole reason that we're testing is in part to know if somebody has COVID-19 or not, but it's really about, do we put infection and prevention control measures in place? And so if I had a symptomatic patient with a negative test, I do not let that stop me from doing infection prevention and control. We still do transmission-based. We still do transmission-based precautions.
Decide whether a patient goes into a COVID unit, for example, or not. In my book, anyways.
It can't. Yeah.
Patients in a COVID unit.
Yeah, I would agree. I would strongly agree with that sentiment. We have had patients who have influenza-like illness, but what we do though with them is repeat testing. If they continue to have symptoms, you keep testing them, and after 3 negative tests, we have had patients where they have tested negative 3 times, and the 4th time they will come back positive. In which case they will be transferred to the COVID unit. But it's really a dicey thing to transfer people just based on symptoms.
That's what I think. Although what we also have is, I have a big facility in Hawaii just now who's experiencing an outbreak. They've had a fun last week. So we have a COVID unit and a PUI unit actually at this point, and that makes sense to me. I just don't want to put PUIs in the COVID unit ever, because I have gone that route in March, and I have regretted that severely. So there's a lot of questions here around testing, and if you want to scan them, but Dr. Edmondson says, since PCR does not correlate with infection, should we stop doing them? I have some opinions on that, but what about Rinva? What do you think about that question? And you are muted right now.
No, I would still test. Yeah. I would still test. The other thing, Robin, mentioned that there is a lot of different tests. And the problem with them is, again, we don't have comparison between them. So you can get tested by one test, be positive because you're probably at the cutoff of that test, and be negative in another, testing another way. The other thing, a test negative also can depend when during your illness you get tested. If it's very early, you might be negative. It depends about, did we do it right? It depends about, did the media was right? Did we keep it at the right temperature? So there's a lot of variable that cause a test to be negative. So I'm sorry, Sabine, what was your question again?
I was just. It's happy hour. Are you having your drink? I'm still at tea time.
No, so I was still using.
If the PCR tests do not correlate with infection, should we stop doing that? And you said no. That was my question, and I think you gave an unequivocal no, because it's not about that person by itself, but it's about the whole community, I think is what we're trying to say here. So there's an issue, Dr. Lin, and Dr. Lin, are you my colleague from Klein-Galland? I don't know, but we just had a slew of what we considered false positives. That was new to me. Can you talk a little bit about that? Who wants to jump in on that one? Rinva? You're now on mute.
Sorry, I can talk about some of my experience here locally. And the issue when you read the literature, no one discusses false positive. Any test, as I'm aware, and Robin and Swati helped me, the positive and the negative depend on the sensitivity and specificity of the test. We know, for example, for the PCR, depending on which test, the sensitivity vary. We don't know much about, I was told by the lab that the specificity is very high. So you should have less false positive. However, what you don't know is, was there a contamination at the lab when they processed your test? So we have seen that, or was it at the cutoff of the reading? And we have seen those when they're repeated with the same sample, with the same lab, are turning negative. I would just not disregard, though, a positive test. I would just look at the patient, look at the situation. The only time where we could say this is definitely a false positive is when you have 500-bed nursing home, everyone tested, and only one patient is positive and has no symptoms, and none of the staff are positive. So it made no sense. And this patient didn't go anywhere. In another nursing home, it was also a nursing home that was COVID negative. 5 were positive, but they were on different floors. And they had no staff that were positive, so it didn't make sense. So it's very hard at this point to know what's a false positive rate. It also depends on the prevalence. So if prevalence is low, there's more likely false positive. But we are probably looking more to learn. We don't have, though, a gold standard to compare to. Like with influenza, you culture. You could say the PCR is probably more sensitive than culture. You know the patient, they're symptomatic. Here, we're dealing with a lot of asymptomatic people. We don't have a gold standard. So it's really very hard to know the sensitivity and specificity of those tests. So you really have to look at the situation before you say this is definitely false positive. Yeah. And you guys can chime in, but this is my own, local experience. And when I called the lab, they said, no, there's no false positive.
Robin, do you have anything to add to that?
I do. So Rinva had mentioned about the prevalence influences how the test should be interpreted. So this is most understandable, I think, with the serology. These are the antibody tests. So no test is perfect. PCR is the best test that we have going. It's not perfect. And the way that we have to make it better is by using our minds and our clinical brains and making decisions based on what we're seeing, not just based on the results of the test. And then when we think about serology, the serologic studies are on the order of 95% sensitive and specific for SARS-CoV-2, IgM, and IgG. That's really good. Some of them are even higher than that. And so when the incidence of or the prevalence of disease is on the order of 5%, those tests are awesome. But when the prevalence of disease is 0.6%, which is about what it is in the nation, then your pre-test probability for either a false positive, your positive predictive value is about 50%. And so is the negative predictive value. In other words, you could flip a coin on serology in many cases. So using that to make decisions about individuals is maybe not such a good idea. Using the serology to make decisions about a region makes sense. And with your brain fully engaged, using those serology results to make decisions about your staff based on what you know about the prevalence or the burden of disease in your building also has the potential to make good sense. But at every step, I think we're always confronted with the fact that epidemiology is local, and we have to make decisions on who and what are in front of us.
So, Swati, have you used serologic testing in your facility? I have not used it. It's not cheap, and I felt it wouldn't on a facility basis. It wouldn't help me to make a decision. Is that?
Yeah, I agree. I agree with you, Sabine and Robin, that serology is really good for population health as a population health measure. I don't think that we have enough data and we have enough benefit to even do serology at this point of time. We're sticking with nasopharyngeal swabs, and One of the things that I would like to highlight is a lot of times, I think Thomas Edward, he has brought up a point where people are testing positive in the nursing home and then going to the hospital and testing negative. And I would point to maybe it's a different lab that, you know, that has tested them, or, you know, I think it's the false negatives are high. So we need to keep that in mind. So 1 in 3 tests could be a false negative. So that is something that we have to keep in mind. We did have a recent incidence of somebody who was tested positive, and then we had 2 negative tests because we are doing that 2 negative tests prior to bringing them back into a nursing home. And then this particular resident was admitted to the hospital with some other condition, and they were negative then, and then tested positive right before discharge. And, you know, all hell broke loose. So that is the other thing. I think there is a study out of South Korea that talks about, you know, fragments that are, you know, that can be shed for a little while, and that may be positive. So again, going back and making sure that we are correlating them with the clinical picture, especially after somebody has already tested, was positive and has tested negative, is important.
Well, here's Tom Edmondson. You're just a fund of good questions here. And I had that kind of question on my list too. How can AMDA help educate physicians and other providers about the pros and cons of various tests? We need help. And I was also going to ask Swati whether, as the leader of the Infection Control Advisory Committee, is AMDA formulating a testing protocol or strategy?
So the short answer is we are not formulating a testing protocol strategy. And I think we have discussed a lot of reasons why, because testing really depends upon what is happening locally, not just with your prevalence, but with your infection control practices, with your availability of PPE, the availability of testing, the time that it takes for the test to come back. So all those factors go into how often are you going to test? Who are you going to test? What is your strategy? And you have to be nimble in your strategy. That's what I think the most important thing is. As things are changing in your community, you got to keep changing with that. So, so we have discussed the principles here, but we don't have any plans to come up with a one-size-fits-all strategy.
Maybe you come up with a nimble strategy that's 3-dimensional and is in an app or something. But I think it might be interesting to put something out there and say, I mean, the things we discussed here, and say, you know, these depend on the factors that you just listed: your facility, your local epidemiology, and your infection control practices. That may be one of the answers. Mm-hmm. And maybe giving different scenarios and then say, this is what we recommend there, and this is what we recommend here.
So one of the things that I did want to say is that there is something in the pipeline, not right now. We have not talked about putting out as a statement, but there may be something coming in a publication. Mm-hmm. So we have been kind of thinking about all this and trying to put that in a document, in a paper. Mm-hmm. So depends on you know, what happens to that paper, right?
What happens next? Yes. And so it's the pros and cons of the various tests. Might be also just a little information sheet that can be updated. Don't print anything because it could be updated. So at this point, I would like to pivot the discussion a little bit to we now have influenza. I'm sorry, God. We now have COVID in the facility, and let's put up the next poll, please.
Sabine, we're going to have influenza soon enough.
I'm thinking about that. Hopefully less. All right. Discontinuing, this is now about discontinuing transmission-based precautions. To discontinue transmission-based precautions of residents with COVID-19, you use a time or symptom-based strategy, and the CDC strategy is listed here, or test-based strategy, 2 negative viral tests at least or equal to 24 hours apart. Please feel free to submit what you do. Let me see whether I can actually submit something. I can't. It's going to be interesting. I don't know what it's going to show.
It's going to be a good poll to know what people practices are right now.
Let me tell you, I've been through a devastating outbreak, and I'm scared. All right. We are sharing the results, and the majority of our audience uses time or symptom-based strategy, and we're quoting the strategy from the CDC here, and a substantial, it's a 60-40 split, uses test-based strategy. And somebody here even said we started with symptom, and now we are with more test availability, we're doing testing. So Rinva, did you experience a outbreak in one of your facilities, or did you accompany an outbreak in a facility? And how did you do it?
I was kind of more like a consultant, and I have helped many facility, like couple of facility go like day to day, kind of what do I do next? And so when we started, so regarding this test, the testing at the beginning, because we did not have a lot of tests, we had to go with symptom-based approach and duration. But right now, because we're in New York State, I think a lot of people are afraid to do anything without clearing a patient by test. So we are not, transferring patients from the hospital to the nursing home if they're test positive, which is a big challenge because some people don't clear for 6 weeks. So I feel bad that they have to stay in the hospital until they're negative, and we don't have locally alternative site for those people to go. So there is kind of pros and cons, and the debate, as Swati said, what does it mean when you're still positive at 6 weeks? Are you infectious or not? And right now, we don't have a 100% answer to say you're definitely not infectious. We know from some data that you cannot culture the virus after 8 or 9 days, but we don't know if that applies to the elderly in the nursing home. So locally, we're very careful, and everyone is using a test-based method to clear patients. And sometimes they have to be on precaution for several weeks, which is kind of the pros and cons and the isolation of these people. And I hope that we'll have more data on the, what does it mean to have a positive PCR at 3 or 4 or 5 weeks. And I'm hoping with more data that we will go back to what we do with flu, which we follow symptoms and some duration. So I'm optimistic that in the near future, we'll have that answer. For example, in, was it South Korea, Swati? They made a decision to go by, more duration and not follow the testing.
And I heard there was a study in Singapore that, and I haven't seen the study, but it was apparently in Nature, looking at this question also and saying that people were not infectious, but those were not nursing home patients. So I'm nervous. Robin, where do you come down on this question? What did you vote for or would have voted for?
I would go with symptom-based strategies, not testing-based strategies. So when people were looking at viral shedding from asymptomatic patients that had COVID, and then looked at the timing of shedding afterward, it's the virus is still detectable by RT-PCR, but it's not detectable in culture, which is what Rinva has said. So we know, so this is a standard for healthy ambulatory adults. And that was in the study in Singapore also did this not in a lab base, but in a contact tracing base, and found out that people weren't transmitting the virus either after a 7 to 8 day window. So based on that laboratory and epidemiological data, for people that have recovered from COVID and are at least 3 days out from their symptoms and 10 days out from the symptom onset, I'm comfortable with letting them come back to do what they need to do. For people that still have symptoms, I'm not. And for people that are still immune compromised, I'm also not comfortable. And my definition of immune compromised is I guess I want to share that with the audience, because sometimes we feel that people that are diabetics or are old are immune compromised, and to some degree that's true, but that's not maybe the most rigorous way to think about this. So when I think about immune compromised, I think about people that would say qualify for a PCV13 vaccine. So these are people that have solid organ tumors, blood-borne tumors, or blood tumors or bone marrow tumors, cancers, people that are on chronic steroids of more than 20 milligrams, for more than, I think it's a month to 3 months per year, HIV, dialysis, and other folks of that nature. So there really is a very clear definition and application of this. And so it's not, I'm worried about this individual, so I'm going to treat them this way, but more about kind of how we should approach them. And this is the basis of how we think about influenza shedding as well. And like we are in some other things, we don't have rigorous answers to this. We're just going by the seat of our pants.
Yeah, I guess I personally remain quite concerned because I have seen a devastating outbreak, and I don't ever want to see that again. So that's just my bias. I think what you said made also a lot of sense. I'm also, and I'm just going to disclose this right now, I'm not too trusting of the CDC, given that they have evolved. Well, not trusting, but I mean, it's not, I interpret everything they say with caution, because we have seen that they've been wrong, or that they had to update their recommendations. So I am concerned that I will learn the hard way that that was not the right recommendation. But on the other hand, I think what you say is also very reasonable.
And I agree that the CDC is doing their best to respond to an evolving situation. And this is why I went back to the primary literature to answer this. So I'm not just taking verbatim or just downloading CDC thoughts. Like, I'm trying to base this in science as well.
No. And I appreciate that. I have a question here from Assad, and I think it's a very good question. He asked about pretty good control in the facility, but wondering about patients who go out for dialysis, and he's afraid of bringing in the disease. And I think he has reason to be afraid, because I've seen quite a few outbreaks, including the first one mediated by a dialysis patient. And I think that highlights also, as far as from a containment standpoint, is we can control hopefully to a certain extent what happens in our facilities, also when we relaxing restrictions. But when people go out, that is where we lose control. And so what would you suggest for patients on dialysis? Very good question. Rinva. Or Swati. First Rinva, then Swati.
Yeah, that's a difficult question. And I was asked that question recently, is like, what do we do with dialysis? At the beginning of the pandemic, we definitely put those patients on transmission-based precaution in their separate room on isolation. And because there were, transmission in dialysis and patient bringing it into the facility as the first patient. Since then, we have seen a lot of infection control policies and in the dialysis, and we haven't seen any more dialysis outbreaks. So locally, we're able to not put those patients on precaution, but monitoring them for signs and symptoms. My thought when I was asked that question, this means this poor patient will never come off isolation ever. And so that's kind of a balance, is like, what is the harm and what's the benefit? And it really changed what we did depending on what was happening locally. So locally, at the beginning, the dialysis, we didn't pay attention that there was transmission dialysis and people were getting infected. More recently, we know that there's a lot of procedures in place to prevent transmission. And so our approach has changed, but it really, Swati probably has a different approach and Robin has a different approach. And really there's no right answer. And you have to put the pros and cons of, what you do, because, we're never going to take those people off precaution, right? Because we're waiting for the second wave.
Always, yeah.
Yeah. So that's,
don't say never. There might be, dare I say it, a vaccine and or treatment. Swati, what's your approach to dialysis patients at this point, with testing or without testing?
So we are still keeping them in isolation, and here is why. It's not just the dialysis facilities that I'm concerned about. I'm also concerned about their exposure during transportation. I know that transportation companies are still trying to maximize, everyone is working under a lot of strain, and they have oftentimes 2 or 3 or 4 patients or residents from different facilities that may be getting transported to that dialysis place. So there's that risk of transmission when people are staying together. We don't do communal anything in our building right now for anyone, for that matter. So that's number one. So I think that the risk still exists. That's number one. Number two, we, as a medical director, I've seen the difference between people who are on transmission-based precautions and people who are not on transmission-based precautions. Essentially, everyone is staying in their room, and we have got to have staff escort people out, so we have, as a facility, put things in place where even people with transmission-based precautions are getting, maybe taken out of the facility, out in the open, and get, their therapy, their, walking around the building, so that they're not in the vicinity of other people, but are still able to, address some of the issues that Rinva has talked about of social isolation. The problem is everyone is socially isolated. I think it depends more upon the staff having to, follow those transmission-based precautions. So our dialysis patients are still on, in a single room. And we are doing active surveillance like we are doing with everyone else, but taking that extra precaution of keeping them in a single room and staff having to wear their gowns while they're going in.
Okay, yeah, I can totally see your perspective as well. We got a few other questions here that I would like to address. Is it okay? And so this is not exactly testing, but these are emerging questions for our peers here. Is it okay to cohort a recovered COVID patient with a new admit from the hospital who had tested negative? Robin?
I think so, as long as that recovered COVID patient is truly no longer symptomatic.
Yeah.
So that needs to be that 10 to 14 days after the onset of symptoms, and not someone who's immune compromised. So the knee replacement person, for example, or the happily demented individual would be a good choice there.
Rinva?
That's a tough question. So your patient is coming from the hospital who was tested negative. I just want to make one point. If you're testing negative in the hospital, it doesn't mean, like, you might be exposed and still in the incubation period. So that patient could potentially develop COVID 3 or 5 days later, but your roommate has already had COVID. So the big question, what we don't have an answer yet, is there reinfection potential?
We don't have evidence of that, though, or do we?
We don't, but we don't know. And Robin thinks no, we don't.
Keeps raising her hand. Seriously, Robin, chime in here.
Go for it.
Go for it. Unmute and go.
All right. So reinfection. And full disclosure, I have my PhD is in immunology, and so I haven't done immunology in a long time. But some things don't change. So what we know about SARS-1 and MERS, which is also a coronavirus, is that the antibodies last for at least 2 to 3 years. And if you have antibody, the whole idea of having antibody is that it protects you against the virus. Otherwise, you wouldn't make antibody. Like, we don't really make dumb antibodies unless have a blood cell issue. So the antibodies are specific and they work. The idea that someone was reinfected with COVID-19 just doesn't make sense to me if they actually recovered. What does make sense is if we had bad testing to begin with, and bad testing kits and interpretation and application of those. And so there was a lot of confusion. So those early findings, and I think the WHO really did not do us any good here, those early findings that happened in February and March and April, especially in places that had a poor source of testing, I think it was not science-based, it was bad testing. There's no indication to me that you can get reinfected with a virus like this in rapid succession. We have at least a couple of years, and we know that immunity fades with time. We know that the older we are, the faster our immunity fades. But I feel pretty confident that we've got 2 or 3 years with good antibody responses. My caveat there is still the people that are immune compromised, and we still have to be careful about those individuals.
Robin, I agree with you, but I'm telling you what people are worried about. That's why I posed that, kind of trick is like how people are thinking. I know, for example, my facility are very worried is, what do we do? Like, one of the questions I received is, I'm in a COVID unit and I have, everyone on transmission-based precaution. And now I have some people who cleared. Is it dangerous to keep them there because they potentially could be infected? I said, no, it's too early. You don't get it again. But they're worried because there's some, kind of rumor that there's a potential of getting reinfected. And that's why,
Let me take shameless advantage of you now and give you the opposite scenario. So you all know that I'm the medical director of the second nursing home that was infected and was broadly written up in the New England Journal and all of that. So I just discussed with the administrator, 51 of our 56 patients have gone through COVID. And we are like, let's set these patients free. Because they, would you agree with that? I mean, they should be able to mingle with each other. Yes. And they should be able to mingle with the staff. Many of the staff had been infected. And they should be able to mingle with their loved ones. Would you agree or disagree?
I agree, but no one is doing it. I just had that thought this morning. They're talking about visitation. Yeah, they're talking about visitation, and they're talking about social isolation. I was thinking, why can't we just have those people that recover from COVID get together, because they all had COVID and they're probably protected. But I think the regulations and the executive orders and the surveyor and everyone is making everyone nervous about what should we do, what's acceptable and what's not acceptable, which is kind of, no one is thinking straight and right.
Well, I want to break that pattern and really go with science more than with rumors and with regulation that don't apply to this particular scenario. So what we have done at my company at Avalon, we have instituted graduation ceremonies from graduating out of COVID that are held outside with a patient's family. And that has just, can you imagine your loved one went through COVID and now you can actually see them, and why not? So I would encourage all of you to think about the patients who've come out on the other end as well. Maybe those that we have tested for several times and they are now, and they're now asymptomatic and truly negative again. So that's a little bit of a plea for all of us to think about those patients. And I think this concludes our COVID Grand Rounds for today. Thank you all for participating in this important discussion. We have all learned much, and some of the pearls were, we need to change our strategy depending on our goals, depending on our local epidemiology, and depending on our facility. And I think that was the most important takeaway for me. a very basic concept. What are you going to do with the tests? If you order a test, what are you going to do with it? How frequently do you test? Well, it all depends. And we talked a lot about the factors it depends on. So I think that was very useful, and a real special thanks to our speakers for sharing their expertise and taking the time in your probably very packed schedule. So AMDA will continue this COVID Grand Rounds as a peer-to-peer discussion, bringing you topics of great interest with up-to-date information. We'll probably have this conversation again, possibly in a couple of months or so. And we really want to make sure that the information we bring you really specifically relates to our population. If you have a suggestion for a topic, please email us. In honor of July 4th, we will not have AMDA COVID Grand Rounds next week. We will see you again on July 9th. Be well, and thank you for all you do for our patients. Thank you very much. Bye-bye.
Thank you.
Thank you.